I'm not very familiar with clinical advocacy, so walk me through a little bit. Are there other companies like yours around, and how are they staffed? And just tell me a little bit more on how you interact with, let's say, my primary physician, and I'm Ruth, and how's my primary physician going to react to your testing and your second opinion?
Sure. Well, so the two questions, Manager. So first, about other businesses that are doing this. We've been doing this for 20 years. In the United States, it's kind of an emerging market. We've been doing it outside the U.S. We cover more than 4 million people in Canada today. So the U.S. has been sort of the latest adopter for some reason, but it's been over the last 5 years that we've started to see this growth. There's very few companies in this business right now. It's hard. And part of the reason is because of the issues that you just raised. There must always be a profound respect for the doctor-patient relationship. And the normal approach to healthcare taken throughout this country and many others is to try to get in between the doctor and their patient. I was moved by the testimony before me talking about worries of some third party being in the exam room. You have to have a supportive interaction with respect with the treating doctors in order for these kinds of programs to work, and it's what we do extremely well.
So I know in the legislation, clinical advocacy is one of the considerations for plan design. When that plan design is formed, do you offer like a set fee? I mean, how are your fees determined, and what are the costs? If you can address that a little bit.
Yeah, we're paid on a per employee per month basis, and when we're paid, we cover everybody in the employee's family, and it's just one fee. Depending on the size of the group, I mean, like with many things in healthcare, the bigger you are as a purchaser, the better pricing you can get. But pricing can anywhere from $3 to $4 per employee per month. Once we've received that $3 to $4 from the employer, there's no other cost to anybody. And our service plugs into whatever kind of plan design you might have. Look, the way to think about this from a Best Doctors perspective, there's health insurance on the one hand, and there's health care on the other hand. And our world is in health care, helping people get the right diagnosis and treatment. How it gets paid for is, certainly if you talk to a patient, the first thing they want is to get well. But how it gets paid for is secondary. But at the end of the day, if you do the health care right, you save money on the health insurance component.
And how large of a staff do you have? How many employees are there?
Worldwide, we have about 400 employees.
400 employees, okay.
And so we're, if you can do a lot of math to understand how common these problems are. They're quite common. The incidence rates of disease in general in the population are about 1 in 100. That's why I mentioned about 1 in 100 people every year are making decisions like this. So what we try to do with employers that we work with is to educate all the employees. We don't need to touch every single one and help them with their medical decisions, but we feel an obligation for everybody to feel educated that, listen, it's okay to ask questions. It's okay to insist on feeling comfortable with the decisions that are being made about you.
And are your services, obviously you flew in from Massachusetts, so is your company just based in Massachusetts? I mean, do you have regional offices, and how do you interact with the patients?
Yeah, for our U.S. customers, most of our people are based in Boston. And for people that are in other countries, we put them in local places. But in markets where we have large numbers of covered people, we like to have local staff. There's a tremendous value of people that know the local landscape, speak with a local accent as opposed to someone like me.
So it must be tele-treatment. So a lot of this must be done electronically through the phone, or, right. I mean, how is...
The primary way we get in touch with people is over the phone. We have the ability to do a lot of things electronically, but healthcare is a funny thing. I mean, people like to be, certainly personal interaction is important. When you're doing the work of actually collecting medical information, it doesn't matter what country you're in or what part of the country you're in, medical information is stored in incredibly disorganized ways. So there's a lot of manual labor that goes into helping people get their records and getting their information, and that has to be done through these types of means that you've described.
Thank you. Mm-hmm. We have a bunch of representatives here. Representative Scripps.
Thank you, Madam Chair. You mentioned a couple of your clients that you work with, and it seems, at least at first take, that they range in size fairly considerably. What is sort of the smallest client that you have, and what is the biggest client that you have?
It's a good question. Smallest, I know that we work with groups where, look, we even have a program where in other countries we sell to individuals. In the United States, the smallest groups we have are, 100 employees or so. The larger ones are like the Northrop Grumman's of the world that have, these are companies with hundreds of thousands of covered people. Speaking just as a business person, it's easier to serve a large group because the implementation costs are then spread across a large population. Again, it's the same issue of efficiency. The bigger you are, the more efficiencies there are in terms of your ability to pay for things. So we like the bigger groups, but we serve smaller ones as well.
And I know that one of the, if I may, I know that one of the proposals in one of the planks of the speaker's proposal is something that looks a lot like clinical advocacy. But if I'm hearing you right, there might be advantages to doing it with a pooled group, as has been proposed. But you could do this with individual school districts across the state as effectively from the patient's perspective, if not administratively.
Yeah, look, as long as we can get to the people, without speaking to the legislation, because I'm from out of town, as long as we can get to the people who are sick, then we can do our work.
Thank you very much.
Representative Bolger.
Thank you, Madam Chair. I wanted to go to the Ruth example. And as we looked at the Ruth example, I assume that her health insurance covered the subsequent treatment she received?
Yes.
So the problem here was that, would you argue that was an insurance coverage issue, or is that a doctor issue? Meaning, did her policy matter with her situation?
Yeah, I want to make sure I understand the question. The way that to think about her case is that this is a medical problem, and the healthcare system writ large was part of what her problem was. Everybody gets rushed through the medical system. 15 minutes with one doctor, 10 minutes with the next, and everybody reading files to decide what's wrong with you. And it's very easy for things to get dropped and to fall through the cracks. So what happened to her is to me almost a public health issue that goes on across the country no matter how your health care gets paid for. So in and of itself, it's not an insurance issue, it's a healthcare system issue. But as I was saying before, the insurance pays the price, except the patient first. But if she had not had the surgery, she would have ended up having the surgery later. It's the old, what's the stitching time saves 9, and it would have been worse.
I understand that. I just wanted to be clear that it wasn't the policy that mattered or caused this. It's a grander issue.
It's a grander issue, exactly. It's a medical issue.
Right, thank you.
Representative Pavlov.
And not trying to put you out of work, but wouldn't it be more beneficial to invest in the system that is letting patients down rather than investing in another process along the way to check that out?
Yes. However, it's not real life experience of people in healthcare. I think that, of course, there's things that could be done to say it's not okay for primary care doctors to have to see 40 patients a day, but it's the way the system works. So maybe at some time, 20, 30, 40, 50 years from now, we can address that issue. But the way I see it is today, if someone is sick, they need the help. And the system is not going to change today. They need an advocate to help them. So, yeah, sure, I would love to not have to do what we do, but it's reality.
This question may be a little bit offline, but we've had no one here from Massachusetts yet, so I'm going to use this opportunity to ask you, since they are in the implementation process of a system somewhat similar to what we're debating in this committee, what's happening there? If you could just make a brief comment.
Well, we're still recovering from the Red Sox loss in the division series with the Angels, so I'm a little still teary-eyed. I don't know enough about what you're proposing here to make a comparison, but the fundamental issue they did in Massachusetts, Governor Romney did, was to make health insurance mandatory for everybody to buy and to create a system that would a statewide exchange to allow insurance companies to provide policies that were cheap enough for people to afford who couldn't afford it. They have not addressed the cost issues, what a lot of people are complaining about, and we've been talking to them about these types of issues as well, saying we have to get our arms around real and immediate impact by improving the quality of care.
Thank you.
Mm-hmm.